So, when we talk about female reproductive system anatomy, we must consider the topographical anatomy of the female pelvis. Well, we have three distinct areas, three separate districts, which are linked both from the structural point of view and from the clinical point of view. We have an anterior district, the middle district, and the posterior district. In the anterior district, we have the bladder and the pelvis, pelvic course of the ureters. And injury to the ureters is the most common intraoperative complication during pelvic surgery. So it's important to know the course of the ureters from the upper pelvic brim to the bladder trigone. We have many clinical conditions that are related to ureter obstruction, and compression of this should be considered as a differential diagnosis in gynecological and also obstetrical clinical cases. We have then a middle district, which is constituted by the genital organs and which are divided into upper and lower genital tract by the pelvic diaphragm. And we have then a posterior district, which is the rectum and colon. These districts are physiologically separated by avascular areas, vesicovaginal septum and rectovaginal septum, that in gynecological surgery are used to separate surgical planes without stromal and visceral sections of the organs. So we go with this septa. Through this septa we manage not to damage and section the visceral organs. This allows also, obviously, to have less complications and a quick recovery. So, as said, let's repeat it: we have anterior district, bladder and pelvic course of the ureters. Middle district, genital organs, which are divided into upper lower genital tract by the pelvic diaphragm, and a posterior district, rectum and colon. The visceral peritoneum that lays exactly over the uterus and over the ligaments, in particular the suspensory ligament of the ovary and broad and round ligaments that are the structures that keep the uterus in its position, the center and in the midline of the pelvis. So, in fact, the uterus is a mobile organ, it's not fixed inside the pelvis, but is kept instead there at the level of the isthmus of the uterus, thanks to the lateral ligaments. So we have these lateral ligaments that keep the uterus in place. And they are also called, these two lateral ligaments are the broad ligament and the cardinal ligament. Then, which are these two ligaments, strong parts of the endopelvic fascia. The endopelvic fascia, what is endopelvic fascia? It's a strengthening of the muscular fascia that covers from the inside the levator ani muscles. This fascia reflects anteriorly over the bladder and over the uterus, then goes back to the posterior walls of the uterus, and then goes back to the rectal colic anterior wall, so it covers everything. As you see here, we have the round ligament, and the ligament of the ovary, and the broad ligament from the pelvic fascia, endopelvic fascia. The mesovarian ligaments are a very interesting region because in gynecology, this specific area is crucial in the understanding and managing of particular conditions like ectopic pregnancies, uterine fibroids, and also cervical cancer that spreads to the lymph nodes of the lateral wall of the pelvis. So we have this broad ligament, which is composed of mesosalpinx, mesovarium, and mesometrium. The suspension structures are the round ligament and the suspensory ligament of the ovary that allow the uterus to have an anterior and posterior mobility. So the uterus can move anteriorly and posteriorly thanks to the round ligament and suspensory ligament of the ovary. The uterus can be antiversus or retroversus, and both conditions are not clinically relevant. So they're not clinically relevant. Interesting. A few decades ago, a marked retroverted uterus was associated with female infertility, and many stereopexis procedures were performed worldwide. Nowadays, this procedure is not anymore indicated, even in the case of very marked retroverted uterus. We have So, the broad ligaments are essential to maintain the uterus inside the pelvis and avoid clinical conditions associated with uterine prolapse, like the descents of the uterus. Urinary bladder is just in front of the isthmus of the uterus and can be found together with the uterine cervix at the level of the vaginal wall. This is where you find all urogynecological conditions such as uterine prolapse and bladder prolapse. This is the vaginal wall. In the vaginal wall we see uterine cervix portion, and vaginal wall we see these conditions such as uterine prolapse and bladder prolapse. Okay, so the uterosacral ligaments, that are two, are the two most important structures that fix the uterus in its position and guarantee the pelvic physiological anatomy. So, okay. Anatomy. Okay, another very important aspect that we have to consider is that when we move the uterus laterally, anteriorly, or posteriorly, we cause traction on the lateral structures. So, for example, during a laparotomic procedure, when we move laterally the uterus, all the vascular structures, like the uterine arteries, the uterine veins, and also the ureters, are stretched. So they first need to be freed from the broad ligaments. And this is what happens during hysterectomy. The vascular structures are clamped and ligated, allowing the ureter to be left in place. And actually 80% of ureter injuries happen during or after hysterectomy or conservative surgical procedures on the uterus. Then, the two sheets of peritoneal covering of the internal genital apparatus determine two areas: the mesosalpinx, which is the portion of the broad ligament that stretches from the ovary to the uterine tube, and the mesovarium, which covers the ovary and ovarian ligament. The mesometrium makes up the rest of the broad ligament. So we have the broad ligament, which is made up of the mesosalpinx, which stretches from the ovary to the uterine tubes. The mesovarium, which covers the ovary and the ovarian ligament, and the mesometrium, which makes up the rest. The uterine arteries and the cervicovaginal arteries both come from the internal iliac artery. and the ovarian vascular district, which supplies the ovarian artery and the fallopian tubes, comes directly from the aorta on the right and from the renal artery on the left. So we have that from the internal iliac artery, we have vaginal arteries and uterine arteries. Then we have the ovarian arteries, which come on the left from the renal artery, and on the right from the aorta. We have a double anastomosis between the corporal artery, which is a branch of the uterine artery, and the ovarian artery. And in that region there is high pressure and high volume, and the isthmus of the salpinx is the place where 70–75% of ectopic pregnancies occur, and the high pressure in the anastomosis is the reason why an ectopic pregnancy is a medical emergency, because the erosion of high pressure arteries can cause quick hemiperitoneum and severe hemorrhage, which requires an emergency surgery. Anyway, the uterus can be subdivided in 3 specific regions. We have a fundus, composed almost completely by muscle, and the fundus is obviously the last part of the uterus. We have a body, which is composed by 50% muscle fibers and 50% connective tissue, and a cervix, which is composed by 95% connective tissue. Okay, in pregnancy it's mainly the body and the fundus of the uterus that become hyperplastic, and the uterine arteries are able to adapt because, remember, of the spiral arrangement around the uterus, which allows them to lengthen upwards along with the uterus. Instead, during pregnancy, the cervix is stretched upwards, and the way contractions propagate can be explained, contractions during pregnancy can be explained by the arrangement of the muscle fibers, called as a whole the plexus. So the plexus is this arrangement of the muscle fibers in the uterus. It is a sort of network of fibers in different planes, from the superficial to the deep layers of the muscle, and from both of these layers, the superficial and deep layers, originate from the angular side of the uterus, and with a spiral pathway they reach the cervix, where they connect with the fibers of the uterosacral ligament and of the broad ligament. This particular orientation of the muscle fibers, you can see this in this picture, is related to how surgical procedures are performed. Typical procedure performed in young patients suffering from leiomyomas, also called uterine fibroids, is myomectomy. It can be performed laparoscopically, laparotomically, and transvaginally. When you perform a myomectomy, you remove the leiomyomas. If there are more than one myoma, the procedure is referred to as multiple myomectomy. So we remove the myoma with this myomectomy. And after the removal of the myomas, you reconstruct the uterine wall in order to preserve the normal contractile activity of the muscle fiber. So if a myoma is located in the upper part of the uterus, a vertical midline hysterectomy is performed, because, as you see, the fibers go vertically. While if it's located in the lower part, a transverse incision is performed. And because you see here, the fibers go in a horizontal way. We do not perform sections of the uterus as to minimize the damage as much as possible. In fact, if the uterine scar is not in the same line as the muscle fibers, there is the risk of having a uterine rupture during labor, which is an emergency situation, which often leads to hysterectomy. Then vascular structure. Vascular structures. We have an internal iliac artery, which is the origin of all the arteries that go to the pelvic organs. We have an inferior vesical artery, a superior vesical artery, uterine arteries, which go laterally through the broad ligament and then bifurcate into the corporal and cervicovaginal branches, which run downwards. Approximately 8 to 10 arcuate arteries originate from each corporal branch and they envelop both the anterior and posterior walls of the uterus for about 1/3 of the thickness of the myometrium. So we have the uterine arteries, which divide into corporal and cervicovaginal. The corporal stay lateral and up, and the cervicovaginals go down. We have from the corporal, we have the origin of the arcuate arteries, which envelop both the anterior and posterior walls of the uterus, and they establish anastomosis with the corresponding arteries from the contralateral side. From the arcuate arteries originate also the radial arteries, which reach the endometrium. Then the external iliac artery is involved in specific oncological conditions. In case we perform a lymphadenectomy because of lymph node metastasis from cervical cancer or lateral demolitive procedures such as radical hysterectomy. It's also very important to consider the relationship between the uterine artery and ureter. And remember that the ureter is always under the uterine artery. There is this mnemonic which says that water passes always under the bridge. So water, meaning urine, in the ureter goes below the artery, which is the bridge. And when we stretch the uterus upwards, as we do during any kind of surgery on the uterus, the free space between the uterine artery and the ureter grows. This way we can separate the two and clamp the artery without risk of injuries to the ureter. The two ovaries are in contact with the ovarian pouch of the peritoneal cavity, and the pouch is a region where we can frequently observe pathological implications due to endometriosis. Remember that endometriosis is a common benign condition of young patients and is caused by implantation of endometrial tissue outside the uterus and inside the pelvic cavity. It's a common cause of chronic pelvic pain, female infertility, and frequent clinical conditions. The ovarian pouch is another area where the ureters can be seen in connection with the peritoneum. This is why peritoneal endometriosis is frequently complicated by ureter obstructions, ureter distortions, or compression due to fibrotic tissue. Therefore, this endometriosis can affect also the ureters. When we perform a salpingectomy, which is removal of the salpinx, we do not sacrifice the uterine circulation, because only one of the two arteries of the anastomosis is sectioned and ligated, while the lower ovarian and mesovarian artery are preserved, so we don't have vascular reduction of that area. When we stretch the uterus upwards, the orientation of the uterine artery is from lateral to medial, and the ureters come from posterior to anterior, and the ureter and the uterine artery are inside the lateral wall of the broad ligaments. and the ligaments must be sectioned when we remove the uterus or when we perform conservative surgery of the upper part of the uterus. It's always important to consider the relationship between the ureter and the uterine artery. When you perform a transvaginal surgery on the uterus is stretched downwards, and the uterine arteries are clamped from downwards. So, anyways, not, I don't. Let's go ahead. Pelvic lymph nodes are essential in the staging of gynecological malignancies, both from the cervix and from the endometrium, less for ovarian cancer, and not at all for vulval cancer and vaginal cancer. So they are important just for cervix and endometrium mainly. The first lymph node region involved in metastatic progression is the parameatrial station, located in the midline of the broad ligament, close to the crossing of the ureter and the uterine artery. Then we have the hypogastric lymph nodal station, the obturator station, and in the late stages the external iliac station and lumbo-aortic station. So we have first parameatrial station in the broad ligament, then hypogastric station, then obturator station, and then external iliac and lumbo-aortic station. The progression of the tumor inside the pelvis is related to metastatic involvement first of the local regional lymph nodal stations, parametrial and parauterine stations, and then to involvement of the vascular structures. Remember that many common gynecological conditions also affect the anterior pelvic area. Due to the location of these masses, we can have also symptoms like urinary GI symptoms, obviously. So here we see some cases. In general, the decision whether to perform conservative surgery or a demolitive one is mainly the age of the patient and the wish to have children. If the patient is a perimenopausal or postmenopausal age, a total hysterectomy must be performed because of the relative risk of uterine sarcomas, malignant transformations of myomas, and because the risk of recurrence of myomas after myectomy is 20–25%. Myomas have very defined capsule composed of stromal tissue that can be easily separated from the uterine muscular wall. So we have stromal tissue and uterine muscular wall. And sometimes it's useful to remove the myomas even though a hysterectomy will be performed, as to shrink the uterine volume and make hysterectomy easier, allowing a better visualization of the vascular structures and ureters. So we can sometimes take out myomas even if we will anyway take out the entire uterus, because it gives better visual on the, gives a better overview of the uterine structures and vessels, so to perform better surgery. Okay, here we see all the structures of the peritoneal floor, of the pelvic floor, and all these structures allow the maintenance of the pelvic continence. And if there is some laxity of these structures, there will be urinary incontinence and fecal incontinence. In gynecology, the perineum extends from the symphysis pubis to the coccyx. coccyx, yeah, and is divided into two components. In gynecology, the perineum extends from the symphysis pubis to the coccyx and is divided into two components. Anteriorly, the urogenital triangle, and posteriorly the anal triangle, so urogenital and anal triangles. The two ischial tuberosities are the points of great interest in obstetrics, because the peritoneum, the peritoneum must be protected in case of delivery complications. Perineum must be protected in case of delivery complications, paying close attention to the superficial transverse perineus muscle, the deep levator ani, and the bulbocavernous muscle and the ischiocavernous muscle. The fibrotendinous center of the perineum is the point where muscular and stromal fibers cross, giving to this point the maximum strength and the maximum resistance to increase in abdominal pressure. If this point is weak, the patient can be at a risk for genital problems. And it's the point where most obstetrical injuries can be identified at the moment of delivery. This is the fibrotendinous center of the perineum. Maximum strength, maximum resistance, also known as the perineal body, it seems. Yeah. Then these injuries during delivery can be prevented through episiotomy, which is a surgical incision of the posterior triangle. The muscles involved in this incision are the transverse superficial perineal muscle and the lower part of the bulbocavernous and the superficial layers of the levator ani. There are three different techniques of episiotomy: median, mediolateral, and lateral. So I said we are involvement of transverse superficial perineum muscle, bulbocavernous muscle, and superficial layers of the levator ani. Okay, the lateral technique gives the largest space for the fetus, but has also the highest risk of complications. The reconstruction must be done in a multi-layer way, and it's common to have rectal lacerations due to macrosomic babies or prolonged delivery, so episiotomy is important, especially in those cases, to avoid urinary or fecal incontinence or predisposition to genital prolapse. There are anatomical variations of the pelvis, and they are implicated in delivery. We have the main difference between them is the transverse diameter, which is essential for the fetus progression from the uterine cavity to the vaginal canal. And the two ischial spines are the 2 points that must be passed by the head of the fetus to guarantee a vaginal delivery. If the transverse diameter is not large enough, a C-section should be performed. The caudal part of the coccyx is not fixed and can be moved in both directions, thus allowing a larger anteroposterior diameter during delivery. So this is the caudal part of the coccyx. The anteroposterior diameter can be examined during delivery by measuring the distance between the sacral promontory and the symphysis pubis. To have a safe vaginal delivery, the diameter should be at least 10-11 centimeters. So we have four different variations of the pelvis: gynecoid, platypeloid, android, and anthropoid. Gynecoid, platypeloid, android, and anthropoid. The fetus starts moving downwards and the cervix has already, then the fetus starts moving downwards and the cervix has already reached 7-8 centimeters dilation, then progression of the fetus can be assessed through these levels. We have a zero station, O station represents the line that passes through the ischial tuberosities. In case of macrosomic babies, the occurrence of incompatibility between the dimensions of the mother and of the baby is quite frequent. Once the O station or zero station is reached, the C-section cannot be performed anymore. The movement of the fetus during its progression is an adaptive rotating movement, thus creating less resistance. Usually a baby is delivered with the occipital bone under the symphysis pubis, thus creating a sort of fulcrum to allow extension of the neck and the disengagement of the head. There can, however, be a physiological variant in which the occipital bone is against the sacral promontory. After the head is disengaged, the shoulders need to pass through the pelvic outlet. One shoulder is fixed under the symphysis pubis and the other disengages. Shoulder dystocia is one of the complications, in fact, of vaginal delivery, so pay attention also to the shoulders.